Hello, and welcome to the second session of today's conference. So my name is Niels. I am Professor of Data Science and Healthcare Improvement at this institute. And we are going to talk for the next 50 minutes about what is probably the most unavoidable topic of our times, artificial intelligence. Specifically, we're going to talk about what is the role of ambient voice technology in improving care. Throughout the session, please, if you have any questions, put them in the Q&A box on the right-hand side of your screen. And don't forget to introduce yourself in the chat if you haven't done so already. Before we turn to ambient voice technology, we're going to start with a short video that introduces the work that we do at this institute on the topic of AI.
AI, data, and digital technology have the potential to reshape healthcare, but so far the focus has often been on the technology itself. Our approach is different. We focus on the needs of people, the healthcare staff, patients, and carers who use and should benefit from AI. For AI to help healthcare professionals do what they are best at, talking to patients and making clinical decisions, good quality evidence is critical. We want to find out how AI can save clinicians time, help prioritize urgent care requests, ease pressure on busy services, and provide better support to patients. We're asking questions like, how does AI impact care services? How do people feel about it? And what are the potential pitfalls and benefits of using AI in healthcare? Our research tests and evaluates AI tools in GP surgeries, hospitals, and other diverse healthcare settings. The evidence we're generating assesses whether AI can improve the quality and productivity of healthcare services, making the best use of AI and maximising the skills of healthcare professionals. In a complex system like the NHS, technology must help to meet healthcare needs, fit into daily practice, save time, and enhance, not replace, the human side of care. We're delivering the evidence-based insights needed to support the effective use of AI and digital technology in healthcare.
So we're going to talk about ambient voice technology in this session, AVT for short. And that's technology that uses AI to help clinicians to document the conversations that they have with their patients. The main reason that many people are very excited about this technology is that it should save time, because the AI does the clinical documentation, and therefore clinicians don't have to do that themselves. And potentially, therefore, it could increase productivity in the NHS. And there is some emerging evidence that it does indeed save time. But obviously, we need more solid evidence, but also there's a lot more to say about technology than that, just that it does save time. There are other effects as well. So we're going to talk about that in this session. So we're going to start with 3 short presentations, and then we're going to move on to a panel discussion with 4 experts in this area. So the first video is going to be presented by Matthew Woodward, who's a research associate at this institute.
Hello. A lot of promises are being made about the benefits of AVT, ambient voice technology, for healthcare, but what's the research evidence behind it? My name is Matthew Woodward. I'm a research associate here at this institute. The literature in this area is developing rapidly. Many studies have been published just in the last 12 months. And broadly speaking, there are 3 topics: time use, quality of the notes, and implementation. There's a really strong narrative that AVT is going to save time on documentation. But when we look at the published studies, there are mixed results. Some studies are showing an improvement of a few seconds per clinical note. Others see no improvement. And notably, there's a real variation between clinicians about the benefit that they see. Another area of study has been the quality of a note output. These are usually lab-based studies, and here we see that scribes generally produce a poorer quality note as measured on things such as the physician documentation quality instrument, which looks at things such as the usefulness of a note and the technical accuracy of a note. However, digital scribes do provide generally a more complete note. They're more likely to capture everything that was said in a consultation. Third area of the literature are generally commentaries that are reflecting on some of the issues around implementing AVTs. And this covers everything from managing the data governance, integrating a new technology with existing systems and EHRs, and also how it might impact on both clinician and patient experience and workflow. Focusing on the time aspect, we have a number of methods available to us as researchers to study how people spend their time. They all have strengths and weaknesses. So surveys and diaries are really good for a self-report measure over an extended period, but data quality can be poor. Activity sampling, where we take random points of time and observe what's happening, is useful again for extended periods, but there can be feasibility issues in getting hold of good quality data. Many of the studies that I've talked about, mentioned and referenced use computer timestamps. So using the electronic health record, they will record when a note was opened and when a note was closed. These are a pretty good proxy for time on documentation, but they don't really tell us if the clinician was interacting with that note during that time. We can get the most valid data from direct observation. So this is where we have an observer in the room directly observing the clinician at work. This gives us really good quality data, but the issue here is it's very resource intensive. So here in the UK, what we need is some really robust evidence for AVT and how it impacts on clinicians' time and other aspects. So here at this institute, we are running a study specifically looking at the use of AVT or digital scribes in primary care. And we're using direct observation as our method to record time use. We think that here the application is likely to be nuanced, partly because GP sees a whole range of consultation types in any given session, and also clinicians have different styles of note-taking and working. Our study design has 3 components. In the first phase, we will be conducting interviews with a range of stakeholders to develop a theory of change. What are the expected outcomes and what are the mechanisms and processes required to get there? The second part of the study is a before and after study to observe how GPs distribute their time across different activities. So in the baseline condition, there'll be no AVT. The clinicians use AVT for a minimum of 4 weeks, and then we do a follow-up observation. We also collect information about the practice population, and a brief interview with the clinician after their observation. The third part of the study is more in-depth interviews with GPs, practice managers, and patients to understand their experiences of using an AVT and the work system aspects that make that work effectively or otherwise. So in summary, this study is to produce evidence to inform the NHS about the impact of AVT on time use. This is not necessarily straightforward, but we have a robust method to do so. And this will be specifically looking at primary care, the first study, as far as we're aware, to do so. So many thanks for listening, and here are some links.
Thank you very much, Matt, for that presentation. Really interesting. Our next presentation is by Marcus Lewis. Marcus is a GP at Abbey Medical Centre in London.
Hi, my name is Dr. Marcus Lewis, and I'm a GP in North London. And I'm going to share with you my personal experience of using AI scribes. So initially, I was drawn to being an early adopter of AI scribes by the promise of reduced documentation burden. My initial reaction was the freedom from anxiety when consultations ran over, knowing that my notes would be automatically generated. Quite soon, obtaining patient consent for AI scribe use quickly became part of my standard consultation opening. I became aware of AI errors, fabrications, which are known as hallucinations, and some of them were obvious and easily corrected. A patient who mentioned to me sadness after their cat died was written up by the scribe as clinical depression, with a fabricated mental health crisis plan and non-existent mental state examination, questions I hadn't even asked the patient. That was easy to pick up, but more subtle are important distortions of time, sequence of symptoms, and even leaving out important aspects of the consultation that was discussed with the patient. Particularly, the AI consistently fails to capture crucial negative findings when I'm asking patients about specific symptoms, or subtle but important details to do with a patient's job, family structure, and other psychosocial details. One day, a colleague's sharp feedback proved quite sobering to me. She found my AI-generated notes were so verbose and so difficult to decode that she had to retake the patient's history entirely. Any time I might have saved for myself was simply transferred to the next clinician who saw the patient. And in my practice, where most patients speak English as a second language, I discovered AI scribes perform poorly with non-standard or accented English and provided no benefit during three-way interpreted consultations. Also, scribes, unlike my typed notes, capture only what was said, not what I might be thinking, feeling, or just my intuition during a consultation. I've got around this partially by adapting how I use them, briefing the AI before consultations with patient backgrounds from recent visits, or important hospital letters or results, and then debriefing afterwards about my thinking, advising the scribe which aspects of the conversation to emphasize in the notes and which things are less important, either minimizing them or leaving them out altogether. A concerning moment came to me when, following up a complex patient I'd seen just 4 weeks earlier, despite reviewing the detailed AI-generated notes, I couldn't remember either the patient or that consultation. And this raised alarm bells for me about whether delegating note writing was affecting my engagement and my recall with my patients' narratives. Over time, I've refined my approach. I've trained the scribe on my preferred documentation style. I now review all outputs very thoroughly before incorporating them into the medical record, and I explicitly document this process because my understanding is that medical legal responsibility for accurate primary care records and any errors that might ensue. Remembering, of course, that the GP notes will follow my patient throughout their life. The responsibility remains mine, not the scribe's or the technology provider. And like any tool, understanding when to use it proves crucial. Some consultations benefit from automated documentation, freeing up my attention for patient interaction. Others prove inaccurate and require traditional note-taking, while simple single-issue consultations often provide no time benefit at all. I also make a point of deliberately scheduling regular clinics where I won't use an AI scribe at all, so that I can maintain my manual documentation skills.
Thank you, Marcus, for that very nuanced view, I think, of what the technology entails. So our final talk is provided by Stella O'Brien, who is patient representative and chair of this institute's Engagement and Involvement Advisory Committee.
Whose voice is it anyway? What does the uptake of ambient voice technology mean for the people whose voices it captures? I'm Stella O'Brien. Why am I talking to you about this? I'm deaf and both a patient and informal carer with a communication need that is seldom met when I interact with the NHS. I have years of experience of reading closed captions and transcriptions as part of my access needs in my everyday working life. I know how indifferent these can be, depending on the microphone, the quality of the audio stream, the choice of language model, and speaker characteristics. Transcriptions can be usefully accurate or demand the ability to decode a cryptic crossword puzzle. I have some knowledge and research interest in speech recognition systems and how the public sometimes has to learn new language and ways of speaking to interact with automated systems, large organisations and the state if we're to fulfil our civic responsibilities and to have our needs met. I've read about the impact of AVT for clinicians, administrators and workflow. Saving 90 seconds on each appointment would generate over 2,000 full-time equivalent worth of GP capacity, delivering more appointments at more convenient times and better continuity of care for those with complex needs. Automated GP referral letters to colleagues in secondary care may remove several points of manual admin failure in the process of obtaining an appointment. I've seen clinicians rhapsodize about the freedom to truly listen to the patient in the room, to build a relationship on connection, not distraction, and a rediscovery of the joy of working in healthcare. I've read that few patients or their carers refuse the use of AVT. They rate these consultations with high satisfaction scores. And one fairly typical patient feedback comment was, "The doctor looked at me rather than his computer for the first time in 30 years. But at present, that's where evaluation seems to focus its reporting, on patient and clinician satisfaction and the admin workflow rather than on the effects on healthcare quality, patient outcomes, and when we might expect to see the increased capacity to serve those with complex needs and to reduce health inequalities. There are parallel realities in which AVT is a sign of a brave new technology-enabled world, and where the 30 years comment is an indictment of a system that hasn't been patient-centred and has been asking people within it to behave in dehumanising ways. The most recognised summary of patient advocacy is, "Nothing about us without us." However, I've yet to see an account of the patient or service user involvement and co-creation of AVT in healthcare settings, whether it's the products, the outputs, the implementation, or ensuring interoperability with other parts of the health and social care system. Engagement and satisfaction aren't outcomes. Is it possible those who already have excellent access to healthcare will continue to have it, and those of us who don't, without changes elsewhere, will be left further behind? I appreciate the fewer opportunities for error in a streamlined workflow, but for some, does this just mean faster access to the bottleneck of a lengthy waiting list? Without outcomes and evaluation, thus uncertainty. Is AVT an overlay of what will remain a system where HCPs continue to work beyond their capacity and with overstretched resources? Because the demographics of the population mean that our demand will continue to increase. Are technology innovations accretions to a legacy system? Why aren't they an invitation to engage with multi-stakeholders to reimagine workflows and interactions? AVT is being deployed rapidly, often without patients knowing it's there. It's shaping our clinical record, the story of someone's health, and interactions in ways that could have real consequences. Patients need information about AVT on websites and available wherever we go for our healthcare. We may want to give blanket permission or on a case-by-case basis, and note this when we use automated check-in. For the future, we need high-profile patient and public involvement in AVT, and the evolution in how it will be deployed in health and social care settings to interact with other AI tools. We need to know that the technology and the systems have been designed with diversity and inclusion in mind. Because ultimately, this isn't about technology, it's about whose voice counts in designing the health and social care we all need.
So thank you very much, Stella, for some very good food for thought, I thought, about what this technology can bring and should bring. So I'm delighted to be joined for the rest of the session by 4 experts on this topic. So we have Stella again, and then we have Tim Horton, who is Assistant Director for Insight and Analysis at the Health Foundation. Majid Hassan, who's a medical malpractice lawyer at Capsticks Solicitors, and Claire Morris, Head of Innovation, Adoption and Collaboration at Cambridge University's Hospitals NHS Trust. So, Tim, if I could go to you first. If this technology does indeed free up time by clinicians, which seems reasonable to assume, I'm conscious that at the Health Foundation you've done work on the question of how would clinicians use such freed up time. Could you tell us what that research told us?
Yeah, of course. And of course, it's the potential for AVT to save time that I think has driven real interest in this from the government and the NHS. We saw in the 10-year plan, and more recently the medium-term planning framework NHS England issued, a real focus on trying to drive this forward. And I think it's that potential prize in terms of saving time that they are focused on. But of course, save time will only lead to the kind of productivity benefits that they are envisaging, that some are envisaging, if the time freed up is used as intended or in ways that will increase productivity. And of course, there are many demands on time in healthcare and many different ways staff might use extra time. The research you talked about, which we did last year, we surveyed around 500 clinical staff and asked them how they might use extra time freed up by technology. Some of it went on extra time on patient care, but some of it went on management work, research work, training work, quality improvement work, admin, reducing unpaid overtime, for example. So there are many different ways in which freed up time might be used. Even if we kind of zoom in and look at extra time for patient care, some of that might go towards increasing the volume of patients treated. But some of it was clear that many of the clinicians we spoke to in that research also envisaged longer, higher quality consultations as a result. Listening to Stella's video just then, thinking about, for example, how we going to make sure this improves healthcare for people with complex needs or facing complex determinants of their health. This could allow extra time in consultations really to have those higher quality conversations that are needed to do that. So I guess the upshot of that research is, yes, there's optimism about time savings from this technology, and that could have all kinds of benefits, but we shouldn't try to map the productivity gains in a simplistic way. It will depend on how staff use that freed up time. And in practice, that will depend really at a local level on the change management and the work planning that goes on around the adoption of AVT, what the vision of it is, and how patients and staff want to see it used to improve healthcare.
Right. Thanks very much, Tim. If I could then go to you, Claire, next, because you're in the middle of this process now. I'm conscious that Cambridge University Hospitals has just started a pilot of AVT 6 weeks ago now, I think. So from your perspective, what is it that a trust like Cambridge University Hospitals needs to do in order to achieve those productivity benefits?
Yeah, it's a really good question, and I think drawing on what Tim said, it's a complex environment. So it's very clear to us. We did some time and motion studies before we started the pilot, and it's very clear that there's huge variations in how clinicians use their time during consultations, and within a single clinician, depending on the consultation type. So productivity gains are not expected to be linearly mapped across all members of the trust. And what we're looking to do actually is to assess the impact on the entire end-to-end clinical documentation workflow. So we already have a reasonably mature tech stack for supporting clinical documentation capture, and we've targeted on those areas where we'd expect AVT to have the largest impact. So we're trying to hit the sweet spots first and see if actually these productivity gains can be realised, and look at those areas where the balance between both the length of consultation and the number of patients that people are seeing may result in time releasings that could result in additional patients to be seen within a clinic. But there are other productivity gains to be had, both in that admin workflow and overall patient the patient outcomes. So it's a complex question, and there are some specialties where AVT is likely to have a bit bigger impact than others. Those that the consultations are more verbose, they have less templated EHR records. And really, we're hoping to find out exactly the answer to your question on how do we realise the maximum impact of productivity gains to be had from AVT.
Thanks. Yes, and I think it's fair to say that we're really just starting to discover, how this technology works in practice, and as you say, how it's going to impact how people spend their time across different settings and specialties, and that's going to be very, very different. So it is really important that we do study that across all those different settings and different specialties. So Majid, if I could go to you next. Marcus Lewis mentioned in his presentation that he records how he has checked the outputs of AVT and documents, so the reviewing process. What's your view on that? Would you say that every clinician should do that? And if they wouldn't do it, what could be possibly the consequences of that?
Thanks, Niels. Lovely to be with you today. I completely agree with Dr. Lewis. 100% you do need to check. The first thing I would say, though, the reason you need to check, and when we go back to the importance of medical records, they're not really for lawyers like me to look over many years down the line. The importance of good quality medical records is continuity of patient care. So, Marcus alluded to the fact that his colleague had to assess the patient again. Good quality notes mean that when the patient is next seen in the surgery or hospital, the clinician understands the journey so far and what they need to know. When we talk about cases, I think Marcus alluded to the fact that ultimately, from a medico-legal point of view, the responsibility rests with him. And I'm afraid he is absolutely right. You won't be able to say, well, it was the AI that produced this note. It's not an adequate reflection. A court will almost certainly want to ask, well, doctor, did you not check the note after it was transcribed? Did you not review to make sure that it was an accurate reflection of your discussion? And this is really hard because often, this may be many years down the line. Now, for a busy clinician who sees, 30, 40, 50 patients, whatever, in a day, it's very hard to say, I remember what was said that day. If it's not in the records. So the importance of the records is absolutely key. The quality of that note, the accuracy of that note. And it may well be that there's been a mishearing mistake by the AVT system. It's recorded the wrong thing. It may have recorded a conversation that it heard in the background within the notes. It may have placed the wrong emphasis on a certain part of the note. There was a case where a child went with an ear infection, and the doctor said, well, despite this raging ear infection, the ear's very red, child's fine, is still in good spirits and is still laughing. And the note recorded a 6-year-old child with hilarious ear infection. Now, completely different to what the clinician intended. So checking that the note reflects exactly what was said and the nature of the discussion is absolutely crucial and should be done all of the time.
Thanks, Majid. So Stella, if I could go to you next. There's been a question in the chat, which I think is very intriguing. So considering the fact that we do know that this technology does make errors, can make errors, do you think it's reasonable? So clinicians will have to ask their patients for consent before they start using AVT. And the question that's been asked in the chat is it reasonable to ask for that consent and for patients to give it, given the fact that we know that technology can make these errors?
I'm fascinated by the notion of informed consent here because I don't think there's a good understanding of the impact of some of the errors. I think there's been a recent interesting paper calling for an impact score for minor errors that don't have much of an impact on patients' healthcare, but also understanding the number of times you can expect to have something which will have a substantial impact on your healthcare. Is it informed consent if we don't know the error rates? And if we don't have access to correct records with which we disagree? I don't think it is.
Thanks. So, Tim, if I could come back to you. So, both Marcus and also a GP in the chat have mentioned that AVT impacts the memory of the interaction. And this aligns with the neuroscience understanding of writing being important to memorize things. So what's your view on this impact of the technology? I don't know to what extent it has already been studied. I'm not aware of studies, maybe you are, but what's your view on how should we deal with this impact of the technology?
It's a fascinating issue. And yes, it's been known for a while that the act of documenting things clinically, yes, it takes time, but it's often been an aid to thinking and reflection. A few years ago, we at the Health Foundation commissioned a study of the potential of automation in general practice, and it looked at this issue. And some of the doctors it interviewed said, well, yes, dictation is helpful, but it wasn't AVT as the AI wasn't as advanced then, but just more basic dictation software. And the GP said, look, this is very useful, but we also sometimes use our note taking to reflect on cases and reflect on our own practice. And what some of them would do then is not just check the notes, but edit them and use them to reflect. You know, it could be that some of the extra time is still spent with the notes in order to get that level of engagement with them. So it's a nice example of a task in healthcare, in this case, documentation, being a more multidimensional just than the capturing of information, but to do with the clinicians' engagement with that information and their own learning. Of course, there's also an issue, just to touch on, with skills as well. It was really interesting listening to Marcus and that idea of sometimes continuing with note-taking yourself, really to maintain your own skills in that. It's a big concern, despite all the potential benefits we can get from AI in healthcare, that if we adopt it without enough thought, it could lead to de-skilling in important ways, as people don't get the chance to practice and use these skills regularly. So finding ways that clinicians and staff can maintain their documentation skills will also be really important too.
So Tim, does that mean, and I'll probably come to you, Claire, in a second as well to ask the same question, but maybe from you first, Tim, you think that means that we're going to see a tension between, the views of politicians and policymakers who would like to use this technology to save time and increase the NHS's productivity, which is something that, frankly, needs to happen. And the fact that if we use technology, there are these unintended consequences that we would like to avoid. But if we're going to avoid them, we might not have the productivity benefits. So how do you see that?
Yeah, it's a good question. I wouldn't call it a tension because the government, are right to be worried about productivity in the NHS. It's something that matters to us all if we're to retain a high quality health service in the face of growing demand. But I guess what I'm cautioning against here is simplistic mappings of potential gains onto benefits. As we're talking about, it's complex. Whether or not you could use release time for seeing more patients or even for longer consultations partly depends on the amounts that it's released in and the opportunities that a member of staff has for using it in that way. That's partly why what we heard earlier, the idea that it might differ across specialties. You could imagine more list-based specialties have more opportunity to see an extra person. That won't be the case for everyone. As I alluded to, there might be other things that time is used on. And actually, just having said that, things like training, things like admin, things like reducing unpaid overtime, these can contribute to productivity too, in a longer term way. There was a really interesting study out from Yale last week, which showed the potential effect of AVT on reducing burnout in clinicians. Well, that's a good thing, and that will improve retention and productivity in a deeper way. So I'd want policymakers and politicians to have their eyes not just on a narrow concept of saving time and seeing an extra patient, but of all the ways in which freed up time might improve productivity, as well as the quality benefits too. We're hoping, as Stella alluded to better interactions between clinicians and patients, higher quality note taking, and hopefully better quality of working life for staff too.
Thanks, Tim. Yeah, that does make a lot of sense. So yeah, the benefits are likely going to be short term, but also medium and long term, and we have to find the right balance between those things. So Claire, how would you see this panning out within your trust? I can imagine, for instance, that you'd find that there are clear benefits of using AVT in a certain specialty, but then there might be individuals who say, well, I prefer not to use it because I feel it impacts the interaction with my patients, and for instance, whether I can memorize what I discuss with them.
Yeah, it's an interesting and partially still open debate internally around how this goes forward. I think, from what Tim was saying, just to follow on to that, there's a little bit here around expectation management and what we should expect to gain. As to whether this should be mandated across all clinicians, I think AI offers us a really exciting opportunity to reimagine how the workflows are put in place. And really, we should be looking at what are the pain points that we're trying to address with this technology, rather than how can I force this technology onto everybody to get an extra patient in per clinic, because that just isn't realistic in terms of an outcome. And I think with AI in general, we tend to have a very siloed mindset of trying to replace a very specific portion of quite a large and complex workflow with something automated, when actually it gives us this chance to reimagine what is the purpose of clinical documentation, what are clinicians using it for, and where will this technology actually address what the pain points are in that kind of end-to-end treatment pathway. And it may be that there are individuals where this has a lot of impact, and we may be looking at a different licensing agreement with vendors where we're looking at a total number of hours per year rather than individual user licenses, and people can dip in and out and match their tech stack to the type of consultation that they're providing. And I guess in this initial pilot, we're trying to understand actually what are the workflow requirements, where do we need additional training for optimized EHR use, digital dictation, AVT, and how do we fit that together to address the different archetypes of consultation that our clinicians are providing. I don't think that this will be a vanilla solution. I don't think that will suit anybody, essentially.
Thanks, Claire. So Stella, if I could go back to you, there's been a number of questions in the chat about this issue of consent that we were discussing, and people have suggested perhaps patients could play a role in checking the outputs of AVT. So what do you think? Is that a reasonable thing, a reasonable solution, and what would be the implications of that?
Inevitably, it's going to be a reasonable solution for a slice of the population that goes to attend GPs. If you are somebody with complex conditions who's already feeling overburdened, perhaps just by the trip to the GP surgery and the logistics of what it took to get you there, no, it's not necessarily reasonable to ask people whose health literacy may have been impoverished by the number of conditions they're living with to check the accuracy of an AVT or to understand its implications into the future. There are many implicit needs embedded in the use of these systems, one of which is addressing the level of health literacy that we have, and what is it reasonable to externalize responsibility for onto individual patients. I can see that some having a look and fact checking your transcript will appeal to people in their 20s to 40s even, but beyond that, it's not necessarily an age-related thing. It's the workload of managing multiple conditions that might make it unreasonable for some people, and I'm not too sure that we have a good understanding of that, or even an adequate one.
Yeah, I agree, and exactly as you say, I think this could be one of the things that sounds like a very good idea, but can then actually exacerbate existing inequalities rather than resolve those. If I could go to Majid as well, so what would be your views on such an approach where patients check the output of AVT, might disagree with their clinician about what was said and what should go into the record?
Yeah, it's a really interesting debate. So let's look at notes at the moment. When notes come across my desk, I don't think GPs currently show the written notes to their patient. The patient may have left the room. The GP writes the notes. They don't I don't think they say, is this an accurate reflection? I completely agree. It is important for using the primary care setting, GP surgeries, to say we are using a ambient voice technology as part of our record keeping process and making sure patients are aware of that. But are we going to take away the benefits of seeing more patients and reducing time and improving the quality of the doctor-patient consultation? Because the doctor, by using this, can sit there and really engage and look at the patient, engage with the patient. Are you going to lose those benefits if, having done all of that, they then need to spend another 5 or 10 minutes with the patient going through the notes? From a medico-legal point of view, it is very common for us to deal with claims, particularly in some GP cases that go to trial, where you have two starkly contrasting versions of events, and the patient will say, that's not what the doctor said. And in those situations, the courts will often approach the case by hearing, certainly those cases that go to trial, by hearing both sides and both witnesses, the GP and the patient. But then they will say, well, what did the notes say? And why would the GP write something that wasn't discussed if it was indeed a contemporaneous note or made shortly thereafter? So I think it's important to absolutely let patients know the tools that are being used. I'm not sure whether you need to get the patient to approve every note, because that could open up a whole different set of issues going forward, practical and otherwise.
Thanks. Yes, I agree. So let's spend the last couple of minutes that we have in this session thinking about what the future of this technology might hold. And I guess, Majid, this is a follow-up question for you straight away. Some people have suggested that rather than having just the AI-generated notes, we could also have the full transcript of the consultation, or even a digital audio recording stored in the patient's record. What would you think? Is that a solution to the issues that we were just discussing, or is it taking us even further away from what we're trying to achieve?
The issue of digital recordings often comes up. I certainly know many surgeons I've worked with and represented who have said, well, actually, I'm going to a system of recording my consultations to get everything there. So it does happen. I suppose providing relevant safeguards are in place around the storage and use of that recording and that data and where it's stored. If all of those boxes are ticked and the governance is in place, then yes, absolutely, it could sit alongside. But again, going back to the very first point that I said, good notes and the skill of writing good notes is really important for continuity of care. As an aside, it provides a good medico-legal evidential basis when looking at what was said and how. I would just, I think there are others better placed than me to answer it, but I think you just need to say, practically, if we have too many systems, how does that all play out? But if you can efficiently have a digital recording sat alongside an AI generated note of the consultation, which has been checked, then that's, again, improving the quality of that journey for the patient.
Yeah, I think it's one of those situations where, the technological opportunities to do these things are there and will become, even more emergent as time progresses. So then there's always a tendency to move in that direction and just use the opportunities, even though, that might not be the direction where we want to head, but there's just the possibility to do it. Stella, you also spoke about, let's try to reimagine the future with this technology. Could you expand on that? What would be your ideal future with this technology?
In my view, we should stop trying to optimize a broken system and truly reimagine what a patient-centered healthcare system would look like with a workforce that has as little friction in their day-to-day activities as possible. We can evaluate outcomes that matter to patients. We can evaluate what helps the workforce perform their jobs in a way that reduces their burnout and actually restores some sense of enjoyment and positive outcomes from their day-to-day lives. There are still so many friction points. We can introduce this AVT, but unless you consent to it at your automated sign-in, and you're going to have to use a part of your consultation saying, yes, I consent to this, or no, I don't. Will it just put you further, more quickly into a system with a massive waiting list that can't see you any faster? Are you still going to be interacting with out-of-date letters from the NHS system? It isn't adequate to apply all these band-aids and new technologies to a system that is still fundamentally not serving the workforce and not adequately serving the current patient need, far less the anticipated need that in order to stand still, the NHS has to meet 50% more demand by 2030, just because of the demographics of an aging population and the health problems of the generations that are coming through. We have to rethink this, and we have to rethink this with all of the stakeholders who have a massive stake in this. That includes patients, but above all, the workforce who are thoroughly burned out by trying to work within a very broken system. And I'm speaking about the IT infrastructure here.
Right. So, Tim, the last word will be for you. So what, in your view, should policymakers do at national, but also regional and perhaps local level to achieve such a vision?
So, first of all, and I guess it captures many of the points that have been made, it's really realizing that getting the goodness out of this, first of all, is going to require providers to be in a place to implement it well, which means the bandwidth to do the planning, any support they need around doing that, for example, time to redesign ways of working, to make sure staff feel confident in using this, and so on and so forth. Picking up on Claire's point from earlier, it's really important that this is demand-led. This is such a powerful technology. It could help with so many things. Let's use it to tackle the problems that patients and staff are telling us they see on the ground, rather than a preordained view about patient volumes or so on or so forth. And then I think just thinking about the broader job of work for government, I think there's a bit further to go on the regulation side as well. We had a little bit of a wrinkle earlier in the year with worry about whether the use of AVT for summarization meant it would be classed as a medical device. It's good to provide clarity around that. I guess more clarity around consent as well. And I know that the government are moving forward on this. I think they've started making a suppliers register for AVT, for example. So there's a range of ways in which government can facilitate this. It's really important that it's demand-led to tackle the problems that are actually happening on the ground, and that providers have the support they need in place to do that.
All right. Well, thank you all very much for a very interesting and insightful discussion. There's lots more to say about this topic. I hope we perhaps can continue the conversation next year or the year after. I'm sure there's going to be further development in this field. We're now going to move on with another brilliant set of lightning talks. So in room 1, Frederica Pascale will discuss integrated, sustainable and resilient healthcare real estate. And in room 2, Peter Hartley will share insights from a national survey on cardiorespiratory training after stroke. So you can select program on the left hand on your screen and enter the talks from there. After the lightning talks, we will have a lunch break. All lightning talks that have taken place will be available on demand over lunch. So if you'd like to catch up with any of them that you have missed, you can do that whilst you're eating your lunch. But please return at 1 p.m. When we will be discussing why is improving timeliness so hard and what can we do about it. Again, thanks very much to the speakers and panelists in this session, and thank you for watching. Bye-bye.